Well, on today's health report, we've already covered two problems, dementia and infections, which contribute significantly to the global burden of disease. If you're a regular health report listener, you'll have heard that phrase a lot. It describes how many years of disability-free life are lost, as well as actual years lost due to premature death, caused by disease's risk factors and injury. The measure is called a disability-adjusted life year, or DALY. By creating a tangible and reproducible measure, the DALY and the burden of disease concepts have transformed thinking and planning of public health and health research around the world. They were created in the early 1980s by Chris Murray, whose life started as a New Zealander, and a Western Australian, Alan Lopez. Chris is now Director of the Institute for Health Metrics and Evaluation at the University of Washington in Seattle, and Alan is Laureate Professor in the School of Population and Global Health at the University of Melbourne. They're both in our Melbourne studio as Chris is on a lightning visit to Australia. Welcome back to the Health Report, both of you.
Thank you, Norman.
Thank you, Norman.
So, Chris, from small beginnings, I think just your institute's got hundreds of people working for it.
Yeah, the Institute's now 450 people focused on measuring health and health expenditure and impact of interventions around the world.
So how granular have the causes of lost disability-adjusted life years become?
We now track about 360 diseases and injuries, and we track about 84 risk factors that account for the patterns that we see around the world.
Now, when you developed this in the early 80s, there was a league table of loss of DALYs, and one of the surprises globally was how high mental health issues were. I think it was number 3 at one point. When you look at the league table now, let's look at the league table of diseases, league table of risk factors. What's shaking out globally?
Well, I think the world is sort of tracking on different trajectories. Outside of sub-Saharan Africa, we're seeing this incredible success story, longer lifespans, a big shift from communicable diseases to the non-communicable causes, with heart disease and cancer at the top. And soon after, many of the conditions that cause disability, like mental health or musculoskeletal disorders, drug abuse, vision loss, hearing loss. And while that sort of the consequences of progress are being seen in most parts of the world, in sub-Saharan Africa, we still have a profile of burden that's really dominated by the big infections, HIV, TB, malaria, diarrhea, pneumonia.
I thought there was convergence. I thought that was one of the surprises, that there was more non-communicable disease in sub-Saharan Africa than we thought, but there's not been as much as you originally predicted?
Oh, there's more than people think. It's that, and the rates in any particular age group are higher in sub-Saharan Africa for NCDs than they are in middle-income and high-income countries. But it's the very young population age structure in Africa that means, in terms of the actual counts of burden, the communicable causes, still are more than 50%. They're still the majority.
One of the issues globally, it's an issue in your home country, the United States, but globally as well, is universal health care and the ability to influence the global burden of disease with universal health care. Is your research illuminating that?
Yes, we've been working very closely with Dr. Tedros, the new Director General of the World Health Organization, and part of that work has been to try to revamp the measurement of universal health coverage by focusing in on outcomes that are very healthcare sensitive and looking at variation in the case fatality rates. One measure of how well the health system's doing is, what fraction of people with pneumonia die even though they get treatment, or what fraction of people survive with some of the treatable cancers. And so by focusing in on those healthcare sensitive outcomes, I think we've got a much better handle on where people are getting needed care with high quality. And then there's a whole series of really interesting questions that is framing about how likely is it that we can achieve the ambitious Sustainable Development Goals for UHC.
So we're in the middle of an election campaign which won't have escaped you in Australia, and the structure of our universal healthcare system is under examination. Are there features of universal healthcare that you've noticed which reduce the burden of disease effectively and cost effectively?
Well, I think as we look across countries, it's not just how much money you spend. I mean, the U.S. is the sad example of that, where spending is one of, first or second in the world per capita in terms of healthcare. But by any of these measures of access and quality of care, The U.S., compared to its peers in the high-income world, doesn't fare so well. Australia has done remarkably well, in terms of comparison in the horse race of health outcomes. It has really caught up very close to Japan in terms of things like life expectancy. And it has, it's really something that other countries are interested in the Australian experience.
Alan Lopez, when you started this work on the global burden of disease, your interest was tobacco and tobacco control. That's where you started off. When you look at tobacco, when you look at obesity, you look at alcohol, and you look at the global burden of disease, what's the picture that's emerging and the trends?
Well, tobacco was a major cause of disease burden 25 years ago when Chris and I first started doing this study. It still is, Norman. It's still a major cause of disease burden, including in countries like Australia. It's responsible for about 10% of healthy years of life loss. So it hasn't gone away, even though we've been successful in bringing down prevalence. About 15% of Australian adults still smoke every day, and they run a threefold excess risk of dying at any time from tobacco. But tobacco is not the only issue. In the last 3 decades, things like obesity, body mass index have increased dramatically. In countries like Australia, it's probably the second or third fattest country on the planet now. And being overweight and obese, particularly obese, carries with it extreme health risks. So we're seeing emergence of risk factors such as obesity that have been very hard to control. No country on the planet seems to have had any success in bringing down the fraction of the population that's overweight and obese.
And where does obesity sit in the league table?
It sits about third or fourth. It depends on how you break it up. But the main ones globally are things like suboptimal or high blood pressure. We take for granted that populations like Australia and the United Kingdom and US have a significant fraction of the population with high blood pressure. But it's actually prevalent in large populations in the developing world, places like China and particularly sub-Saharan Africa. So high blood pressure is a major issue. So is tobacco, so is poor diet. And we've seen several aspects of poor diet that have contributed to disease burden in a significant way. Alcohol use causes a lot of disease and injury, not only fatal outcomes, but a lot of non-fatal disease burden as well.
Now, Alan, you've spent, Chris has tended to focus more on the global picture and mathematical modelling, which we'll come back to in a moment. You've tended to focus more on the country, on looking at countries and the burden of disease locally and getting accurate measurement. You've been funded by Bloomberg to do this. Just tell us about some of the work you've been doing, because you've got this interesting concept called verbal autopsies.
That's right, Norman. One of the fundamental things Chris and I discovered a couple of decades ago was that to really reduce uncertainty in what we're measuring in terms of disease burden, we need to focus on what people are dying from. If we don't have some handle with some reliability on the major causes of death in populations, then we're going to have significant uncertainty in our estimates. And one way to reduce that is to work with countries to improve the quality of their cause of death systems. We take it for granted in Australia or the US when someone dies that a doctor will reliably certify what they died from, and that by aggregating those data, governments in these countries have reliable information on which to act, and by and large they do. But in many developing countries in the region here, Indonesia, Philippines, Sri Lanka, even China, those data are not readily available. And so one needs to think creatively about how can we cost-effectively help these countries to leapfrog the 100 years of investment that countries like Australia put in order for them to get reasonably reliable information on leading causes of death today. And one of the most promising techniques to do that is a thing called verbal autopsy, where trained interviewers, and they do not need to be doctors, but community health workers who are well trained, interview a family for 20 minutes, and using algorithms that Chris and I and others have developed, you can then reasonably reliably predict the cause of death in those communities.
Any surprises there?
Oh, big surprises. For example, in Solomon Islands, where we've done this, we've now collected over 500 verbal autopsies, and it made the front page of the Solomon Islands Times, where they said we're all dying from heart disease and stroke in much, or at least in much greater fractions than we had predicted. We thought we were still dying from measles, malaria and TB. So
it's reprising the early 80s in the sense of the Global Burden of Disease study.
Exactly.
So when you both look at the future based on what you know now and the trends, Chris, what does your modelling tell you about health systems, where we're going and what we can do about it?
So we years ago, 20 plus years ago, Alan and I had developed some very simplistic forecasts. And then this last fall, we've actually launched a much more sophisticated sort of future scenario platform, which allows us to sort of think both what's likely to occur and then what are the ways we can change the trajectory. And that analysis says that this transition towards NCDs is likely to continue. Life expectancy is likely to continue to grow, but probably at a slower pace because of some of the factors like obesity that are coming down on the trajectory for many countries. And this sort of slowdown in the decline in cardiovascular disease that we've observed in places like Australia or the US or the UK. Those combined say that the future looks positive, but some of that progress is at risk. We also sort of frame a better, worse scenario, and the range between better and worse, which is really driven by how well we manage the big risk factors and manage the growth of healthcare systems, is really quite large.
And briefly, Alan, one of the concepts 20 odd years ago was best buy. What's the best buy at the moment in prevention around the world?
Well, I'd be looking at the main causes of health loss in populations, Norman, things like high blood pressure. What can you do about it that would bring down levels of blood pressure in population? Even a small change in a large risk like high blood pressure would yield significant population health benefits. So we know we have established treatments for bringing down blood pressure. Why are we not getting these treatments to the population in need? They're off patent, so the cost of these treatments is not great. So something in our health system that is not functioning in order to bring down these disease burdens through more effective treatment. Same with tobacco. We know what to do.
Luke, thank you very much to you both. Professor Chris Murray is Director of the Institute for Health Metrics and Evaluation at the University of Washington, Seattle, and Professor Alan Lopez is in the School of Population and Global Health at the University of Melbourne. That's the Health Report for this week. Hope you can join me next time.